And I would also like to thank the organizing committee of the Vietnamese Association of Orthodontists and the World Implant Orthodontic Society for this opportunity to speak in front of you and talk about the biomechanics of clear aligner treatment. A brief introduction of myself. I'm currently working as an associate professor at the Department of Orthodontics, Asan Medical Center located in South Korea. And I've been aligned APEC faculty since 2019. And I actively started using Invisalign since 2016. Actually, I had my first case in 2008 as an orthodontic resident, and then I started actively using Invisalign since 2016. So today I'm going to talk about how we're going to control anchorage for different types of complex malocclusions, including the AP correction, such as skeletal class 2, skeletal class 3, and anchorage for vertical correction, such as open bite, anterior open bite, and deep bite. And I'll briefly discuss about the innovations that Align Technology has made through the years, including the optimized attachments, smart shred material, and smart stage features. And then I'm going to close with cases that I'm the expansion of the maxilla and also mandibular advancement for growing children. So this is a hospital that I work at. It's called Asan Medical Center. This is the Han River, and it's by the shore, southern shore of the Han River. And this is the medical school. It's right next to the hospital. And the reason the hospital's name is Asan Medical Center is he is the founder of the Hyundai Group. It's well known for their cars. And his nickname is Asan. That's why it's called Asan Medical Center. And this is our boss. He is the son of the founder. And he is the president of Hyundai Car. And he is the grandson of the founder. So this is my clinic. I enjoy using digital tools such as control scanners, CBCTs, and all the other softwares associated with those. So today I'll be talking about biomechanics. And biomechanics, as all of us know, is the most important part when we are planning for orthodontic treatment. And biomechanics is important because we have to understand the force system that is built into our appliances and how our body will react to those forces. So, as in the morning, Dr. Nanda, he already discussed about the shape-driven appliance and force-driven appliance. Brief recap from the morning session. Shape-driven appliance for aligners would be the traditional plaster-based clear aligners, where we cut the teeth and move those teeth as where we want them to be, and then we just use a thermoform sheet, a suck-down apparatus to make the clear aligners. And nowadays, digital technology has evolved, and we have different types of digital tools, such as control scanners instead of alginate impression, to take the impression of our teeth, of our patient's teeth, and design in the digital space and create a force system mainly by using attachments and other features that I'll be discussing about to create a force system that will move the tooth where we want them to be. And this is a more precise system than just displacing the teeth where we want our teeth to go, you know? So the three key innovations behind Invisalign treatment is Smart Force. Actually, the material is called smart track material, and the smart force features and smart stage technology. So smart track is, as everyone knows, is a new material that Align developed after years of R&D to deliver a force that is very constant compared to the other types of thermoform sheets. And smart force features, there are many different features for smart force features, and they are optimized attachments, you can see here, power ridges, and the latest technology is smart force aligner activation. So aligner activation is, they change the shape of the aligner instead of using attachments. So Invisalign is also trying to get rid of those attachments because they're very unesthetic, as we all know, and it takes time to bond these attachments, and they fail, right? So they are putting more energy into R&D to develop a system that minimizes the use of attachments, and I will discuss about this in the latter part of the presentation. And third is smart stage. So smart stage means you stage the movement in a smart way, obviously, which means that you're moving certain types of teeth one at a time to bring about the most accurate results, as we have planned in the SUČT check. So first is smart track material. It's a multi-layer. That's the most distinguished feature for the smart track material. It's a multi-layer, transparent material engineered over 8 years time with over 260 material variations developed and evaluated. And this material exerts gentle, constant force that enables doctors to better control tooth movements. And I'm sure a lot of the doctors here have already seen this graph of the force decay for the smart track material compared to EX30, which is a previous material that Invisalign used, and other co-polyester materials by other companies. So it's important that, yeah, I know in the morning I heard lectures by Graphy, and the force system is a little bit different because that's a whole different material, but still among the thermoformed aligner materials, I think Smart Track delivers a very constant force, and there's very little plastic deformation, so it makes treatment very, very easy compared to the conventional stuck-down thermoformed aligners. So the structure of Smart Track is as shown on the left. So 3 layers. In the center, there is co-polyester. This is the hard material. So it holds the structure of the whole aligner. And on the inside and outside, there are polyurethane that is coated over the co-polyester. So polyurethane is the soft part, which allows for bending when we exert forces, right, to the aligner. And after the patent ended, other manufacturers, such as Endura, they kind of copied Invisalign, I think, by using multi-layer. And what they did is they switched. So they put the polyurethane in the inside and the rigid, hard layer of co-polyester on the outside. And this will be less, so it's a whole different system because what we need is a soft outside so that when the aligner bends, there is minimal plastic deformation and it delivers a constant force. And when you switch the orientation, in the inside we need a skeleton to hold structure, but here in the center is a very soft polyurethane that will not help hold the shape of the aligner. So when the aligner bends, the softer side, the outside of the aligner will have tension, and the inside will have compression. And that's where we need high elasticity, not in the inside. Okay? And in the center, we need a hard, rigid material for structural stability. And this is what makes Invisalign a very a clear liner that it has a very low, that holds a very constant force over time. So I want you to remember that Invisalign creates force. It creates a force system to move teeth to a desired position. It's not a shape-driven appliance, it's a force-driven appliance. So I think this slide is very important for me because when I was learning Invisalign for the first time, there was a speaker from Japan. He said, the most important thing is patient compliance. So if the patient does not wear the aligners, it will not work. It doesn't matter how good the ClinCheck design is. If the patient is not compliant, which means wearing the aligner 21 hours at least out of 24 hours, and wearing the elastics that we have prescribed, if they don't comply, the whole system is not going to work. Because we all know that teeth move based on a low and constant force, and low and continuous force. And then, of course, ClinCheck design is very, very important. So in order to design the ClinCheck efficiently, we need to understand the force system, which is also called biomechanics. So we have to know the biomechanical principles. And of course, on the basis of everything, diagnosis and treatment plan is very, very fundamental. So in orthodontics, diagnosis, it just doesn't mean that the patient is class 2, class 3. It means that we are identifying the etiologic factors that have led the patient to a certain condition, such as mouth breathing, thumb sucking, or clenching, or tongue thrusting. So many of the etiological factors are associated with functions. So we need to identify those factors that have led to a certain type of malocclusion. And of course, based on the diagnosis, we will have to decide whether we will extract or not extract. So all of these keys are very important to successful Invisalign treatment. So what I do when I see my patients with Invisalign, the first few months of treatment is very important. I try to see if the patient is compliant. So if the patient is wearing at least 21 hours of Invisalign per day. Because if that fails, then I'm not sure if I can finish treatment, right? So in the first few months, if the patient seems like they don't wear full time, then I try to let them understand why wearing time is important. So let's get into the biomechanics for non-extraction treatment. Upper molar distalization case. Class 2, she came with a chief complaint of lip protrusion. But as you can see, she has a very convex profile with a very small mandible, lower face. And she has a slight open bite with a large overjet. And by looking at her face, we can be tempted to extract. But since her jaw is so small, that I didn't think that it was right to extract her premolars, to retract the lips to fit the small lower face, so that her face would be too flat. So I told her to not extract and just distalize the molars to relieve some crowding and also retract her upper incisors. So you can see some carving in the upper arch.
Giải chân chúc và đóng cái cắn hở cho
And she also has scissor bite on the left side.
cắn kéo ở phía bên trái.
This is her lateral step,
Đây là phim sọ nghiêng của bệnh nhân.
small mandible,
Là bệnh nhân có cái cằm
procline incisors,
răng cửa thì vô
panoramic radiograph.
ngã ngoài ha.
She has third
Đây là
molars
phim răng
impacted.
của bệnh nhân. Bệnh nhân có những
And you can see that she has a very small condylar head with some signs of arthritic changes. So I had to take a CBCT and take a look at her condyles. And you can see here that her condylar head is very small, very flattened, and maybe she has some arthritic changes earlier. But at that time, I could see that she had a cortical bone lining that was intact. So I concluded that her condyles were stable.
và bệnh nhân này thì xong
So I planned for non-extraction treatment
cục xương thì nó vẫn ổn cho nên là
and
cô chẩn đoán là
distalized the upper molars
đây là
sequentially.
nguyên trách của bệnh nhân.
And also I corrected the
Thì chúng ta
scissors
sẽ có
bite.
nhiều cái dây xa và sau đó thì mình tạo
And you
khoảng
can
để giải chân
see
chúc và kéo luôn
that
giảm
I
cho bệnh nhân.
placed some bite rams.
Tôi đặt một số cái pad
And importantly, when I'm distalizing, I placed class 2 elastics.
và khi mà tôi dây xa thì tôi sử dụng thêm thun
Let me
hạng
show
2.
you again. Here you can see that I placed a precision hook
Và đây là
and a button cutout,
cái hút
and I had the patient wear elastics.
cái button cut, cái cửa sổ để gắn
And the
button.
reason
Sau đó thì
is
mình hai.
We all know that there is action and reaction. This is Newton's third law. For every action, there is an equal and opposite reaction. So if I am applying a force to distalize the upper molar one by one sequentially,
Đặt một cái lực để mình
there is the same amount of force but in the opposite direction on the rest of the teeth.
nó được tác động lên những cái
So
răng
the
còn lại.
rest of the teeth
Thì những cái răng còn lại nó sẽ
have a force, have a mesializing force. So what I have to do is fight this force because I don't want protrusion, right? So what I did is I had the patient wear class 2 elastics. And we call
và chúng ta sẽ gọi
this
nó là
movement of the anterior
cái
teeth
phần mà
anchorage
cái
loss.
răng ở phía trước này nó hiện tượng.
So anchorage is defined as resistance to unwanted tooth movement.
Thiết kế để mà
So in order to prevent the unwanted movement of incisor proclination while I was distalizing,
tạo ra được những
I had the
hạn
patient
chế
wear
những
class
cái
2 elastics.
phần răng trước nó bị bung ra.
And on the left is the initial scan, and on the right is after I finished molar distalization. Since the patient was really compliant with wearing the appliance as well as the elastics, the molar distalization was really very efficient. You can see that the molar keys corrected to class 1. But there was one small problem. So on the right side, if you look at the first molar, lower first molar, it looks fine. But on the left side, if you look here, the lower first molar on the left side showed mesial tipping because of the elastics. I'll show you in a second. Yeah. Here you can see that the lower first molar is mesially tipped from initial. So I had to correct this problem. So this is the additional liner. And also, I wanted to fully retract her incisors, her upper incisors. So I decided to use tags to maximally retract her upper incisors. So what I did is I placed power ridges on her upper canines. You can see here. These are the power ridges. And I plan for placing a tag in the upper posterior area. And this time I am fully retracting the upper incisors, and I'm also correcting the angulation of the lower molars. So this is the clean check for her second set of aligners. So I placed tags. So by using tags, I'm going to fight the reaction forces, as we are distalizing, the anterior part is not going forward. So I'm connecting a power chain here from the pad to the power arm. So this is after I bonded the power arm, and I'm retracting the canine with the power chain. It's very important that you apply a very light force, otherwise the tooth will rotate, especially when the wearing time is less. So you can see that the retraction is well contained. This is the lateral ceph. So I recommend you doctors take the lateral cephs periodically to see what's going on, because in the clin check, you're not really sure what's going on in the patient's mouth, because clin check is an ideal setup, or that's our treatment goal, but we need to know what's really happening in the patient's mouth. And in order to see that, the only way is to take a lateral ceph. So, comparison of before and after treatment, we can see some retraction of the upper incisor, and the molars were distalized. And we can see a small unexpected change in the mandible. The mandible moved a little bit backwards. And if you look at the superposition, the mandible was repositioned to a posterior position. And you see here in the upper teeth, molars were distalized and the incisors were
Trên thì
retracted.
chúng ta thấy là răng cối thì được di xa và răng cửa thì được kéo lui. Và sau khi mà tôi chụp cái phim combi CT sau điều trị
so you can see that there was a shift in the mandible. So this is her CR, and she had a habit of protruding her jaw. We also call it dual bite or Sunday bite, So she had a COCR discrepancy. So this is right side, left side. So same change before and after treatment. So we always have to consider this discrepancy between CO and CR, because many of the class 2 patients, especially who have open bite, they likely have some arthritic changes in their TMJ, and they tend to protrude their jaws because it goes back too much. So this is debonding, this is the finished treatment results, and this is retention, very stable. So her condyles were stable. So anchorage control for sequential molar distalization. You can do intermaxillary elastics for light class 2 cases, not very comprehensive, cases. And for those cases who require very maximum retraction with a lot of molar distalization, I recommend that you use pads. And you can either use power arms, or you could just place precision hooks in the canine, and you can have the patient wear elastics from the precision hooks to the pad. So the second option, power arm, you're just placing this force on a single tooth. So there's a chance of the tooth that is the power arm is attached to, it can rotate a little bit if you apply too much force. So it's a little bit more technique sensitive. But if you use this elastics from precision cutouts, it's less fail-safe, but you're applying this destabilization force on the whole dentition, right? So you would need a heavier force to control the loss of anchorage. So the first level that I use for intermaxillary elastics is I usually use 1/4 inch light wire, and in some cases I use heavy. And for power arms, I try to measure the force, and I try to keep it between 120 and 130 grams. And if I'm using elastics to connect it to the head, I use 1/4 inch, 6 ounce. That would be heavy elastics. So you need heavier force if you are trying to retract the whole dentition and prevent the interiors from declining. So when we do non-extraction treatment for class 2 malocclusion, we would typically do molar sequential distalization. Personally, I think it's very technique sensitive. It's kind of difficult because it's very easy to lose anchorage, which means that the incisors procline easily if we don't have a good anchorage control. So anchorage is very, very critical, and that's why I recommend that you doctors take the lateral ceph periodically to check how the incisors are moving. If they stay in the same position, that will be okay, but in some cases, when the patient is not compliant with the elastics, or if the force for the power arms and the elastics to connect it to the head, if it's too weak, the force is too low, the incisors can comply. So please check maybe every 6 to 9 months to see how the incisors are moving. And again, clean check is our ideal treatment goal. And in real patient's mouth, it can be different. So we need to compare with our clean check and the patient's mouth and see how our treatment plan is going. And if there is too much discrepancy between those two, I would recommend that you just stop and do additional liners. So just a quick review of this treatment protocol for molar distalization. So yeah, same slide. Patient compliance is very important. Next is extraction. 20s, male patient in his 20s. Protrusion, slightly class 2. But this patient, yeah, we decided to extract the upper premolars because he has some protrusion and his mandible was not very deficient, right? So we tried to reduce the overjet by extracting the upper premolars. This is his lateral ceph. Very overjet. And this is the panoramic radiograph. And also, if you look at his upper molars, they are already distally tipped. And if we try to distalize these molars, it would not work. They're already distally tipped. So there's no room for distalization, right? So definitely this, I think this is definitely extraction case. So we plan for first premolar extraction, and we are closing space. And you see all these attachments, and you see the power ridges to control the cork of the incisors. So when you plan for a clean check, this is the normal sequence that I use. So during the process of this diagnosis and treatment plan, I have my goal. So I know where I want to put my teeth at the end of treatment. And in order to get that treatment, I would understand which types of force system I need to design. And I apply that force system to the clean check. So if you look at the clean check, on the bottom left, there is a menu called Tables, and if you go to that icon, if you click, you can see the tooth movement table. And it shows the amount of tooth movement for each tooth. the amount of extrusion, intrusion, translation, buccolingual, translation, mesodistal, rotation, angulation, and inclination. And if you see the top row, these are the tooth numbers. And you can see here the blue shaded teeth. And those teeth mean that align did something in their aligners. So that's called aligner activation. And you can see here upper incisors, you see a blue shaded area. So we know that there is some features, a specialized feature for controlling the torque of the incisors. And also in the lower front teeth, you can see that there are blue shaded areas. You can see in the clean check that, I'll show you the clean check one more time. We have intruded the lower incisors, so they have applied some special feature for lower incisor intrusion. And I will discuss about it later. And you can see the coverages. And I will show you how the treatment went. This is after premolar extraction. And I actually planned for maximum anchorage, so I placed tags, but in the middle I just cut it because I didn't think that I needed maximum anchorage. So we're retracting the incisors, and you can see that the molar angulation is already dissolated, so it's not indicated for molar crystallization. So this is in the middle. This is 9 months after the initial lateral step to see how treatment is going. And this is the superposition, and you can see that the upper incisor is well controlled, the torque is well controlled. We call it control tipping, and the lower incisors are kept vertically, and almost no signs of vertical bowing. The patient was really compliant, and that is one of the reasons that the treatment was successful. And this is after maybe about one year. And I am taking the panoramic radiograph. The reason that I take panoramic radiograph is to see that the roots are parallel and the angulation is not compromised. This is all because of the attachments, the vertical attachments. Let me show you. These attachments to control the angulation of the teeth. And this is towards the end of treatment. Yeah. So you can see that his protrusions improved. See the smile. And if you look at the root angulation, I think it's very good. It's very well controlled. And the torque, let me show you. This is the debonding lateral step. This is the mid-treatment lateral step. This is debonding. And if you look at the superposition, the upper incisor shows body retraction. So the torque is very, very well controlled with the midline. I was very amazed. Actually, at first I was kind of skeptical that if that power reaches, that little linear thing, this depression on the aligner, wouldn't work. You know, I was kind of skeptical, but it works really, really well. You can see here, this is evidence, right? So I compared before and after. This is a clean check. So this is superposition of before and after. So this is where we started. This is the initial position, and this is the final position of the clean check. Yeah. And if you look at the numbers, upper incisors here, the inclination changes of the clean check. It says buccally 3.7 degrees, and for the left central incisor, buccally 6.3 degrees. So in the clean check, I proclined the upper incisors by 3.78 degrees and 6.38 degrees.
và 6.3 độ.
So we need to do a little bit of over-engineering.
Ở đây là
So
chỉnh nối ạ.
we call it also overcorrection, right?
Người ta gọi đây là chỉnh nối.
So when we plan our plan check, we need to build these kinds of
Plan check thì mình sẽ cần phải
over-engineering techniques in order to get the result that we are aiming for.
cái răng nó bị mất to trong quá trình đóng.
So should we distalize or should we
Bây giờ mình
extract?
nói là quyết định là mình nên chia xa hay là mình nhổ răng.
There's a paper on distalization using the palatal plate
So sánh giữa
in the
cái chia
Korean
xa
journal,
với cái
and they use this palatal plate
mình
to
sẽ thấy là
distalize
họng cái để
the class 2 patients,
ở những bệnh nhân sai.
and they compare the patients who underwent premolar extraction.
Nếu mà bệnh nhân có nhổ
And in the results, they show that the amount of incisor retraction for molar distalization, non-extraction, was 3.4 millimeters, and premolar extraction 5.3 millimeters.
3 mm.
And the incisor retroclination was 7.3 degrees for non-extraction
7.3 độ.
and 14.8 degrees for premolar
là
extraction.
14.8
This is for brackets, fixed brackets. And I think the reason that the incisor retroclination is greater for premolar extraction,
Mình sẽ thấy rằng là
when we use brackets, it's even more difficult to control the torque. The reason is that there is a huge plate in the bracket slot between the wire and the bracket slot. And even if we use a full-size wire, there is still at least 10 degrees of play. So I think it's more easy, honestly. I do use a lot of brackets too for my premolar extraction cases. But you know, we have to do a lot of stuff. You know, twisting the wire, giving reverse curves to get the desired torque of the upper and lower incisors. But in the clean check, all we have to do is just set the desired position and just do a little bit of maybe like 5 degrees of over-engineering, you know? Then all we have to do is just give the appliance to the patient. And another paper on molar distalization, they concluded that relapse in the maxillary first molars was 12%. And 35% of the intrusion amount was relapse. So they showed in their figure that their patients had a mean distalization of 3.37 millimeters, but they relapsed by about 12%, and they also intruded the molars by 1 millimeter for the second molar, and about 30% was relapsed. So this is my rule, whether I'm going to distalize or extract. So if the patient needs distalization of less than 2 millimeters, I would try distalization with Invisalign and have the patient wear class 2 elastics or use pads with power arms or precision cuts. But if more than 2 millimeters is required, that would be very difficult. So I would just choose to extract. And other factors I would consider is, of course, the facial profile. If the patient has protrusion, distalization is not going to fix that because we need to distalize a lot in order to really retract the incisors so that the facial, the soft tissue profile will change. And also, if the molars are mesially tipped, it's easier to distalize because it's tipping, right? But if the molars are already upright or already distally tipped, it's very, very difficult to distalize those molars with very long-term stability. And if you choose to distalize rather than extract, anchorage is very important. So it's kind of difficult to keep the incisors from proclining. So you should bear in mind that you have to watch closely. And for extraction, because we're extracting teeth and we're retracting the incisors, anchorage preparation is less critical. So why is incisor torque control important? I just want to share briefly a case of premolar extraction using brackets. This girl, she came she complained of protrusion.
Bệnh nhân than phiền là bị
So,
vô răng.
no question. It's an extraction case, right? So we extracted both upper and lower first premolars.
Chúng ta sẽ nhổ
We
bốn
use
cái răng
brackets.
cuối nhỏ thứ nhất.
This is an old case,
Ở đây là cái ca cũ của
actually
tôi.
from another doctor.
Tôi nhổ một
So
cái
we
ca này,
close
ca
the
này
space,
bằng mắt
the
cài.
treatment's finished.
Ở đây là
The patient was very, very happy. If you look at a lateral profile,
mình nhìn thấy cái
it
tiếp
looks
xúc
very
của bệnh
different,
nhân nhìn
it's
rất
very
là khác biệt,
improved,
đúng không?
right?
Cải thiện rất là nhiều.
But if you look at her smile,
Nhưng mà nhìn cái nụ cười á,
we made a huge gummy smile. This is a
chúng ta đã
disaster,
thấy là
right?
nó
But luckily the patient was not complaining about this. So it, we
rất là
just,
nhiều.
actually it's not me. Yeah. So if you compare the before and after lateral set, the upper incisors are retracted, but if you do the superposition of the two x-rays, this is before and this is after, so I just superimpose the two lateral sets, and you can see there is a lot of torque loss.
Bất động rất là nhiều.
And the problem with torque loss is when we lose torque,
Thì khi mà chúng ta bất động
the incise comes down.
thì cái răng cửa nó sẽ bị trồi.
See? Here, this is before, this is after. So that's why the gum smile is created. So incisor inclination means we are looking at the angulation from the mesiodistal axis, and we call this inclination.
Chúng ta gọi là inclination là độ.
And the importance of incisor inclination, first, it retains the teeth in the cortical bone. Dr. Naldo showed us in the morning a case of a patient who had a face retainer bonded for a long time, and because they were braided, the incisor kind of moved, right? And second, of course, aesthetics. And third, it's very important for the function of the TMJ because of the interincisal angle that guides the jaw when they are functioning. Also, it's in one of the 6 keys of Dr. Andrews of normal occlusion. And here, key 3 is correct crown inclination. So if you look up his paper, his original paper, Dr. Andrews' paper, he shows in this figure that a normal incisor inclination is very, very important. Because if you have a very upright incisors, even if there is no two-sides discrepancy, the occlusion will not be stable, like on the left side. So, sorry, if you have a very upright incisors, even if you have normal overjet, you will have space when the molars are in class 1, even if there is no two-sides discrepancy. So it's very important that you don't lose torque in the incisors. So when we retract, when we apply a retraction force to a tooth, it moves like this, right? It rotates, and we call this a moment. And we call this force, and this is the distance. And this distance is the distance from the force to the center of resistance. So the moment of a force is defined as the measures of the tendency of a force to cause a body to rotate about a specific point or axis. So moment is force times distance. The distance is also called
Cái moment đó là nó
R.
sẽ tạo ra từ cái moment xoay.
So the center of
Tạo ra một cái
resistance,
lực. Khi mà
I
cái lực
just
nó ở
talked
xa
about
cái
it,
tâm cản của cái
and
lực.
this is the center of resistance. And when we apply force
Nhưng mà
or
cái chấm màu
retraction
xanh đó là
force,
cái tâm
a
cản. Khi
moment
mà
is
chúng ta tạo ra cái lực ở
created,
trên cái thân răng thì nó sẽ tạo ra
and
một cái moment
these
xoay.
two forces are called equivalent forces. So when we lose torque,
Thì khi mà chúng ta
the
bất
vertical
ngờ
position can change.
thì cái vị trí theo chiều đứng của cái răng nó
So
sẽ
what
thay
we have to do in order to control the torque, we have to create a counter moment,
thì chúng ta phải tạo ra cái
the
moment
same
nó
amount of
khác
moment,
để
but
mà
in
nó
an opposite
trung
direction,
hòa lại
right? Because we have
với
to
cái
fight
moment
this
xoay nằm
moment,
trong răng.
and we will have bodily movement,
Thì chúng ta sẽ
traction.
tạo ra được một cái di chuyển tận
And
tiết.
with brackets, what we did is we twist the wire,
thì trong cái hệ thống mà
we
nó
give a
làm gì?
third
Chúng
order
ta
bend,
sẽ bẻ cái dây,
and we put in the
bẻ
bracket.
dây thứ ba và chúng ta đưa cái dây đó
So
vào
when
trong
the
cái
wire is
mắc cài.
twisted and
Khi mà cái
inserted
dây
into
nó
the
đã
bracket,
được bẻ ngược lại rồi thì
it
cái
creates a
dây nó từ
couple.
từ nó sẽ tạo ra cái moment nó khác. Và
So
nó tạo ra
how
cái
can
kích
we
thước nhỏ
make
trong cái
this
hộc
kind
mắc
of
cài và
force
từ từ
with
nó
the
tạo ra cái
liners?
moment nó khác để di chuyển cái chân răng vào phía bên trong.
Power ridges.
Thì ở với cái mắc cài gì?
So
Với
power
mắc cài là như
ridges
vậy, còn với cái
are
thì
depressions
chúng ta sẽ làm
in
gì?
the
Nó tạo
cervical
ra cái gọi là bao
margin of the
cái
aligner.
bao nó sẽ
So
là
it
cái phần
pushes
mềm vào
here,
phía mặt phần trong của
and
bạn
also at the same time, there's also an indentation here in the incisal of the lingual surface that pushes outwards. So these two forces will make a rotation force, a moment,
thì nó cũng sẽ tạo ra một
to
cái lực
fight
cái cặp
the
lực để
lingual
tạo
tipping
ra một
moment.
cái moment
So
làm
this
cho cái chân răng
moment is created,
xoay vào trong, nghiêng vào trong
and we will be able to control the torque
thì đó là
of
cái
the
cách mà chúng ta
incisor.
kiểm soát cái tầm chân răng.
So I looked up some other appliances, other removable appliances,
Và chúng ta
because
thấy nhiều
aligners are
số
also removable appliances,
cái
right?
cụ tháo lắp.
And I found in this book, I was having a seminar with my residents actually, and I came to this chapter, and I found a very similar feature in this appliance called Vao appliance. This is like an activator for class 2. It's a removable appliance. And they have the same concept of applying two forces here and here. And if you see here, very, very similar. They have a spring that is pushing the cervical of the upper incisor. And in the lingual, they have this plastic that pushes the incisor from the incisal edge outwards. So the moment is created to control torque. Also, many of you know this appliance, closure appliance. This is also for correction of plastic malfunction. And they also have this torquing springs to control the upper incisal torque. Same concept, but a different appliance. So I want to stress that Invisalign creates force. It's a force-driven appliance. It's just not shaping the teeth as where we want them to go. No? So we're creating a force system to get a desired tooth movement. And they're all based on biomechanical principles in orthodontics. And the power ridges, so it's automatically placed in the clip check. We can ask the people there to place them, but it's automatically placed based on the angulation changes, inclination changes before and after treatment in the clip check. And the threshold of 3 degrees is the threshold. So if the incisor has to move 3 degrees, if the incisor needs more than 3 degrees of lingual report, a power ridge is placed automatically. And for the upper, you may have only one in the buccal side, or if you need more torque, they will add in the lingual too. So you can either have one or a set of aligners, a set of power ridges, depending on the amount of torque that is needed. And this is just showing the different generations of clinical innovations. And I want to talk about G6. And G6 is the generation in which they invented the optimized attachments for extraction cases. So in this case, G6 was not placed. I don't know, but they have their own internal, criteria for placing G6. But for premolar extractions, the first premolar extractions, they usually place G6. And what G6 does is, this is G6 protocol. So this is another patient that I planned for upper and lower first premolar extraction. And you can see that these optimized attachments are placed to control the angulation of the roots, not the inclination. The inclination is power ridges, But these
Thì cái bao này
optimized
là
attachments
cái hỗ
are
trợ kiểm soát
there
độ.
to control the
Còn
second
cái
order
cặp ở tác mình
angulations.
sẽ giúp hỗ trợ kiểm
So,
soát độ nghiêng
let
của
me show
răng
you here.
trong cái quá trình mà đóng
So
khỏe
it's
của
for
răng.
angulation control.
Thì
So
cái này nó
we
cũng là
call
một cái
this
sự
this
kiểm soát
part
trong bộ răng
the active
trong cái
surface.
trục nghiêng cực
So
xa.
the force is applied
Nó
to
sẽ có
this
một cái
flat
cặp
active surface
F1 và F2
here
đặt
and
vào
here.
trong hai cái
So
ấn
we
tắc
push
tối hóa
and
ở
push,
cái phần
and this will create
bề
a
mặt hoạt hóa
moment
của hai ấn tắc
to
tối hóa
distally
này
move the root
tạo ra
when we
cái
are retracting the teeth.
moment làm di chuyển
And
cái
also
chân
when
răng
we need to
xa.
correct the angulation of the incisor, we have
Và đương
these
nhiên là cái
optimized attachments
cặp ấn tắc ở đây cũng có thể áp
to
dụng vào trên cái răng cửa
make a force to distally
tạo ra
move
cái
the
cặp cân
root
đối để mà di chuyển cái chân răng.
here and here.
À.
And for the posterior,
Và cho cái răng sau thì
when we are retracting the incisors,
khi mà chúng ta kéo lui cái phần răng cửa,
the
còn
posterior
để
teeth,
đóng cái khoảng
the
mặt răng
root
của cái
um,
răng sau thì nó
should
hơi
not
di động một
move.
chút xíu.
So they should
Hoặc
not
là neo chặt tối đa.
mesially tip, right? So in order to prevent mesial tipping of the posterior
Phòng
root,
ngừa cái sự mà
posterior
đi
teeth,
gần của các răng
they place
khối
these.
nhỏ và khối lớn.
Let me
Chúng
show
ta
you
sẽ
here.
có những cái attachment.
So these optimized attachments
Thì
are
ở
there
attachment tối ưu hóa này nó
to
sẽ ở đó và nó
prevent
có cái
mesial
phần
tipping.
bề mặt hoạt
So
hóa để nó đặt
force
cái
is
lực vào
applied
cái
here.
lực đó nó
So
sẽ
this surface is called the
chặn
active
lại
surface.
để nó ngăn ngừa cái sự
So
đi gần
force
của
is
các răng,
directly
thân răng, các răng
applied
khối nhỏ và khối lớn
perpendicular to
ở phía
this
sau cái
surface,
mặt
active
răng.
surface, here and here. You see the blue arrows?
Để mọi người nhìn thấy cái mũi tên
So
màu
the
xanh.
forces are applied here so that the crown
Thì cái
will
chỗ mũi
not
tên màu xanh là cái
tip
chỗ mà cái lực
easily.
nó sẽ áp vào ha.
During
Dùng cái lực
explosion.
áp ở cái chỗ đó thì nó sẽ tạo
These
ra
are
cái
called
moment
active
giống như
surface.
vậy.
And it will lead this kind of movement by pushing on these active surfaces.
Nó sẽ di chuyển cái thân cái để cản
And
trở
a
lại
set
cái
of aligners, a set of optimized attachments here, pushing from here and pushing from this side
trên cái
will
răng nằm thì nó
create
sẽ tạo ra cái
this
moment
kind
cho
of
cái
movement
như
to
vậy ngược chiều kim đồng hồ
move the root distally when we
để
are
mà di
closing
xa
space.
cái chân răng 3.
This is just showing what I just said about the G6
Đây là cái
protocol
bản đồ mà
for
cho
premolar
tất cả những cái chân răng
extraction.
mà tôi vừa phân tích.
So these are optimized anchorage attachments. So they also fight loss of anchorage when we close space, and optimized retraction attachments. Same concept, you know, just controlling the second order of the tooth. And for the incisors, we are having those power ridges for torque control. So I want to discuss a little bit more about optimized attachments. So this is the template for the attachment. And this is a real aligner. So aligner shape is different from the template. So it's designed so that the force is applied only on this surface. So other surface, there is room in the aligner. That's why it's designed bigger, you know? So this is what an optimized attachment is. You can also see here that there is gap here and there's no gap, right? So that means that this is the active surface. This is my patient's attachment template, and the upper one is the first aligner. So I bonded the attachment using the attachment template, and I brought her first aligner, and then I had her weight outside, and then I put the utility wax to see how the size is different. So we had this small shape attachment, and the patient is wearing this aligner, right? And that means that there will be gaps here, and only this part is getting the force. So this is called the active surface. And this is an optimized attachment for extrusion, and this surface will be the active surface for extrusion. Also, I took an intro photo to show you. So the upper photo is the patient is wearing the template, attachment template. You can see here for the upper incisor. And this is after wearing aligner number 1. You can see the difference here and here for the canine. This is the template, attachment template, and this is the aligner. You can see how greater
bên dưới
the
đó là cái
attachment
bên dưới
area
ngay trung
is
gian
for
nó
the
sẽ
liner.
có cái khoảng hở đây.
So only this part is contacting
Mình sẽ thấy là
and
cái
getting
khay
the
nó chỉ
force.
tác động vào
So
bề mặt
it's
hai
more
khóa của
precise.
attachment tối ưu
The
hóa
force
thôi
control is more
để
precise.
tạo ra cái
And
lực
we
nó
have
kiểm soát tốt hơn, chính xác hơn
greater efficiency
để
in
cho cái di chuyển
attaining
răng nó
the
sẽ
type of tooth
chính xác
movement,
hơn và
movement that we want. So one more time, G6 protocol.
Mình sẽ thấy đây là cái gói G6 nó đóng bạn hiệu đăng như thế nào đấy ạ.
And if you hover your mouse over these features,
Khi mà mình
it
đưa
shows
tiếp tục
you what they are.
cái attachment tối hóa này thì nó sẽ cho các bạn thấy tên của các attachment
And
tối
there
hóa
are
đây
different
này.
types
Nó có
of
rất là nhiều
optimized
loại attachment
attachments.
tối hóa của Invisalign.
This one is for
Cái đầu tiên là attachment
extrusion,
tối hóa chồi răng.
and these
Cái thứ
are
hai
for
đó là
rotation,
attachment tối hóa xoay
and
răng.
this part is
Thứ ba
the
là
active
attachment.
surface.
Mình sẽ thấy ở đây ở cái vùng
And
thẳng
these
hiện
I
tại đó là
showed
bề
you,
mặt hàng
this
hóa.
is for root
Cái thứ
control.
ba là attachment tối hóa kiểm soát chân răng.
And this one is often placed on the lateral incisor, upper incisor, because lateral incisor is often very difficult to move, to control with the liners, because it has a very small and round shape. So the multiplane optimized attachments are often placed there. And also for deep bite correction, and this is for anchorage, for premolar extraction case. So this multiplane movement is possible with this attachment. And see that there is no attachment here, but there's a blue arrow, right? This means aligner activation. Yeah. There's no attachment, but they morph the aligner in this area to apply force to push the tooth from here so that we can rotate the lateral incisor. So the difference, you should know the difference between optimized attachments and aligner activation. So aligner activation is a change in the shape of the aligner, whereas attachments change the shape of the tooth, right? Aligner activation changes the shape of the aligner so that it applies force to the active surface of the attachment of the tooth surface. So it can be applied on the active surface of the attachment, or it could be applied just to a tooth surface where we want the force to be applied to. So in this example, this is the clinch check, and the attachment is designed like this, and this red dotted line is the active surface. This is where the force is applied to. And this is the shape of the aligner that is manufactured. You can see the difference in the angulation of this active surface part. The attachment is angulated this way, but the real aligner is made with an active surface of this angulation. So this means that there is a mismatch of the two active surfaces. And if the patient puts on this aligner on this tooth, this part will contact, right? And the force will be generated here, closer to the tooth surface. Yeah. So this is how the aligner activation works. So you need to understand that it's very important to bond your attachments with accuracy, because a lot of times, if you put too much resin on the template, attachment template, when you bond the attachments, they are not close to the tooth surface, but it's like kind of bulky, fatter than planned, and there's like a egg fry shape on the border of the attachment. I'm sure you have, many of you have seen that, and that's very, very bad, because this part is the most important part. And if you have excess resin here, this is not going to work. Yeah. So you need to make sure that you place, you don't over contour the attachments, because they won't work then. These are just conventional attachments. They don't have active surface.
thì không có bề mặt
It
hoàn
just
toàn,
changes the shape of the tooth.
nó chỉ thay đổi hình dạng của cái răng thôi, giúp gắn lên răng giúp thay đổi hình dạng của cái răng.
And this is the criteria for placing optimized attachments for different types of movement. And optimized attachments are automatically placed in the clinch check according to Align's internal criteria. And these are the criteria. Actually, they're not internal criteria. They tell you the criteria
Đây là
for
những cái tiêu
placing
chí
different
hoặc
types
tiêu chí
of
để đặt
attachments.
những loại attachment
And
phù
you
hợp.
can also request
Và
to
các bác sĩ
place
cũng có thể yêu cầu
optimized attachments if you
nhân
want.
viên của Align để đặt những cái attachment tối ưu hóa này.
And next is correction of
Tiếp
deep
theo là
bite.
mình sẽ nói về việc điều trị cắn sâu ạ.
So deep bite, I had some difficulties in the early days
Trong những lúc
because
đầu tiên khi tôi bắt đầu
it
điều
was
trị
very
cắn
difficult to
thai,
intrude the
gặp khó
lower
khăn
incisors,
khi
right?
mà điều trị những ca cắn sâu.
And in the morning, again, Dr. Nanda, he also discussed about how it's very difficult to intrude the lower
Và sáng
incisors.
hôm nay bác sĩ Nanda cũng giải thích tại sao
This patient, she came with a chief complaint of her incisors,
đó là cái răng cửa
class
của
2.
đây đây một ca sáng cắn thai 2.
You can see that she's a class 2 div 2, very
Đây là một
upright
ca
upper
sáng cắn thai
incisors
2 với răng cửa
with
trên nó rất là rộng,
crowding
đúng không ạ? Chen chúc
and deep bite.
và cắn sâu.
Lateral step, class 2, very upright incisors,
Hạng 2 và mình sẽ thấy là cái trục răng cửa hàm trên nó khá là thẳng đứng.
panoramic radiograph,
Phim toàn cảnh
and this is her clinch
và đây
check.
là clean check của bệnh nhân.
So I intruded the upper and lower incisors,
Răng cửa hàm trên ạ.
but at the same time, she had a class 2 malocclusion,
Bệnh nhân nó
right?
sáng cắn thai 2, do đó là
So I had planned to distalize her upper dentition,
hàm trên
and at the same time, I'm proclining her upper incisor.
cái răng cửa hàm trên này.
And you know, in the beginning of the presentation, I showed you a case for upper molar distalization, that the reaction force will procline the upper incisors. But in this case, because she has a very upright upper incisor, this reaction force is helping me, right, to upright the very retroclined incisors. So I'm using that reaction force
Tôi dùng cái phản lực của
while I'm correcting class 2 molar relationship,
quan hạng 2
and I'm also correcting the deep bite, and I'm correcting her retroclined incisors.
chỉnh lại cái trục cái răng cửa hàm
So,
trên.
and at the same time, because I want to distalize her upper molars, I plan for class 2 elastics using the precision
hàm
hooks.
hạng 2 với
See
các
here?
cục ở răng 3 trên và răng 6 dưới.
And I also plan for attachments because I want controlled
Vì tôi muốn kiểm soát
tipping of the molars.
của cái răng cối lớn.
And also because
Và
her
bởi vì là
upper incisors are compliant, there's also power ridges to control the torque.
để kiểm soát tàu của những cái răng cửa hàm trên này.
And when we
Và khi
designed to
thiết kế
intrude lower incisors,
răng cửa hàm dưới á,
the resultant force
thì cái
was not pure
nó
intrusion.
không phải là một cái luống răng
The
chính.
resultant force vector was retraction and intrusion. And
Còn
Align
đây,
realized
nó
this
sẽ
is
làm
one of the
cho răng này,
reasons
nó là
that
lý
it's
do
so
vì sao
difficult to intrude the lower
rất là
incisors.
khó để đúng cái răng cửa hàm dưới.
So what they did is they wanted to change this vector for
Làm
lower
thay đổi cái
incisor
tổng hợp của
intrusion
cái răng này
by adding this pressure area here in the lingual of the lower incisors to change this
thay
vector
đổi cái vector tổng hợp lực ở
to
đây
a more
để cho cái việc tổng hợp
true
của cái vực răng nó sẽ
intrusion
đi qua
along
cái
the tooth axis.
dọc theo cái trục răng tạo nên cái luống răng tuyệt
So
đối.
that's why they added the pressure
Đó là lý
area
do vì sao họ thêm cái
for lower
tăng
incisor
điểm lõm
intrusion. And this feature is available for lower incisors
rất là hiệu quả cho cái răng cửa hàm dưới
upper lower incisors and
cũng
lower
như là cái
canines.
răng cửa hàm trên và răng nằm hàm dưới luôn.
You can't really see
Các bác sĩ
those
sẽ
pressure
xem
areas
cái
of the
điểm lõm này
lingual of the incisors. You can
ở
also
bên trong răng
you
cửa
can
hàm
only
dưới
see on the
thì các bác sĩ sẽ
prescription
thấy
sheet
trên những
like
cái tờ
this. It's
tổng quan điều
indicated
trị
here
nó
that
sẽ có những
the
cái
pressure areas have been
vòng
applied.
tròn màu xanh cho thấy là những cái răng mà nó có được áp dụng cái tính năng lõm vùng lõm này.
And I would like to discuss about the G8
Và tiếp theo mình sẽ
protocol
nói về cái gói cường 8
launched in
vào
2021.
năm từ
And they
Của năm
also
2021
came up with a special feature for lower incisor intrusion.
nó rất là hiệu quả trong
And
cái
it's
trường hợp
aligner
lỗ mũi cái.
activation. So I said aligner activation is the change in the shape of the aligner.
Tôi nói là một nửa kết hoạt khay đó, sự thay đổi
So
hình
what they
dạng khay.
did is,
Và người ta
so
phát hiện
they were trying to figure out why it's difficult to intrude the lower incisors.
Tôi sẽ giải thích là
And
tại
they
sao nó
realized
khó.
that
Cái răng cửa hàm dưới
when
rất
the
là
incisors
và khi lún cái răng cửa
are
hàm
not level, when they're
dưới,
like,
trường sai cấp cắn
their
là
level
cái
is
răng cửa
all
hàm dưới nó
different.
không mức độ.
Different
Có những cái
forces
răng thấp
need
khác
to be
nhau.
applied to each
Do đó
tooth.
sẽ cần những cái lực khác nhau cho
So they calibrated the amount of intrusion force that is applied for
cửa hàm
each
dưới là
tooth.
bao nhiêu.
So let me explain here. This is my patient. This is the superposition
Đây là chồng phim chồng hình
of before and after treatment. So you can see that the lower lateral incisor
cái răng cửa bên
has more intrusion plans
nó sẽ cần phải
than
lún
the
nhiều
lower
hơn là cái
right
răng
central
cửa giữa hàm
incisor,
dưới,
right?
đúng không ạ?
But this difference is so small
Cái lượng khác biệt này nó không quá
that
nhiều.
this force is too small to
Do đó cái
intrude
sự khác biệt
this
về lượng
lower right
giữa
central
cái răng cửa giữa
incisor.
và cái răng cửa bên này.
But this one has more discrepancy, right? So this tooth will have more intrusion force than this tooth.
Răng 42 nó sẽ
So
nhiều hơn là cái răng 41 lực nó
it will be easier to intrude this tooth than this tooth. So they realized that for teeth that have very small amount of changes required,
sẽ có sự khác biệt.
they increase the force.
Do
So
đó
in the
là
clinch
bên
check,
sẽ phải tính toán để
they
cái răng
over-engineer
42 hơn.
intrusion of these teeth.
Do đó là
with
thiết kế
small
mình sẽ
amounts
thấy
of
là chỉnh
changes.
lún vị trí sau
So
cùng
that's
của răng cửa hai
internal
cái răng
clinch check, I guess. So it's not clinch check, internal software. So they calibrated the intrusion force that these teeth will receive enough amount for intrusion
để đảm bảo là
to
tất
be
cả các răng nó đạt
happen.
cái lực cần thiết để mà lún cái răng.
So that's what it's all about. And we can see that this kind of aligner activation is applied when we look at the tooth movement table here.
Mình sẽ nhìn trên cái bảng
Sorry,
nhìn trên
here,
răng này,
the
mình
lower
sẽ thấy là
incisors.
cái răng cửa hàm
And
dưới
if you magnify, you see this blue shaded area. This means that there has been aligner activation plans on these teeth, and they don't really tell you which kind of aligner activation, but we can see from the tooth movement table that because we have intruded here, right, that aligner activation is designed. So it was this patient.
Đây là bệnh nhân của tôi ạ.
So let me show you how the case went.
Và đây là tiến trình của cái ca này.
So we are distalizing. You can see that
Đây
our
các bác sĩ sẽ thấy
premolars
là
are
tôi di xa răng
distalized.
cuối lớn hàm trên đây ạ.
Distalized
Di xa ạ, có khai thư
very
những cái răng
well.
có
Now
nhỏ đây.
her molars
Tiến
quite
trình di xa rất
small.
là tốt. Bây giờ bệnh nhân đã đưa
And
về
you
quay
can
răng
also
cuối lớn
see
hàm.
that at the same time her upper incisors are confined because of the reaction force, and also because her incisors are corrected, the overbite,
Cải thiện thì
the
cái
deep
độ
bite
cắn
is
phổi
corrected also. So if you compare with the initial,
so sánh trước và sau đấy ạ. Độ cắn phổi đã được cải thiện.
the deep bite has been normalized, right?
Đã đưa về độ cắn phổi bình thường.
So the reason for this patient's deep bite was
Lý do vì
the
sao cái
incisor
cắn phổi
torque.
này
So if we normalize the
cải thiện,
incisor
đó là
torque,
chấn chỉnh lại cái độ
the deep bite is automatically
cái răng
resolved.
cửa hàm trên, do đó là cái độ cắn phổi đã được cải thiện.
Another patient in her 50s, severe deep bite.
Đây là một bệnh nhân khác
You
khoảng
can
50 tuổi.
even see the lower
Bệnh nhân thấy cái tình
incisors.
trạng cắn sau của
Also, she's class 2.
gần như là không thấy cái răng cửa hàm
So
dưới.
if you see this patient and you only plan for intrusion of the upper and lower incisors, you will not be able to correct her molar-passenger molar relationship, and what you'll end up with is a large overjet. And that large overjet with the normal overbite, you will not be able to have a stable occlusion, right? So it's important to diagnose and see that you will also have to correct the sagittal as well as the vertical
Phát
problem.
hiện ra là bệnh nhân có cả
So
vấn đề
she's a
trước
class
trước
2,
sau và cả vấn đề trên
severe deep bite,
nên là bệnh nhân có cái độ
extruded
cắn sau
upper and lower
rất là
incisors.
trầm trọng ở trên cái phim sậu nhiên.
This is a clinch
Và đây
track.
là phim
Even if they have the GA protocol to intrude the lower incisors more effectively, you also have to over-engineer. So I try to do the clean check to make the patient almost edge to edge, almost like open bite. You definitely have to do this because otherwise you're not going to be able to correct the deep bite.
Để mà trên thực tế chúng ta sẽ tạo
So
ra
this
một
is the clean check,
nhưng mà chúng ta coi cái clean check này á,
and I delivered the attachments.
và
And you can also see here on the tooth movement table, here the lower 6 anteriors, you see that the amount of intrusion is a lot here, right? 2 millimeters, 4 millimeters, 4 millimeters, 3 millimeters, and there are black dots here. And you see the blue shaded tooth numbers, which means that there have been aligner activation designed on these teeth. And also in the upper incisors are blue shaded, which means that aligner activation is built in there. And also there is power ridges to correct the torque of the upper incisors.
và tối ưu hóa trên từng răng, cá nhân hóa trên từng răng để nó thể hiện được cái hiệu quả tốt nhất.
So the patient is
Tôi
wearing
thấy
the
là bệnh nhân
aligners,
này đang mang máng
and I'm also distalizing.
và và cũng đang di
And
xa
this is the
ở
final.
răng. Ở đây là cái kết
Yeah,
thúc
you
của bệnh
see that I planned for
Mọi người
almost
thấy là
an
chúng
open
ta
bite, but this is
đã thiết
the
kế ở trên
result.
cái clean check ra một cái
This is the
overbite
result.
rất là cạn đúng không ạ? Nhưng mà trên thực tế thì chúng ta đã chỉ có đạt được
Visual
vào
photo,
cái độ cao
after treatment,
bình thường thôi, chứ nó không có rất là cạn như
panoramic
clean check
radiograph.
clean check đâu ạ.
This is her set before treatment.
Ở đây là phim
gần đối đầu
This
luôn
is
rồi.
after treatment.
và sau điều trị.
So you can see that the lower incisors and the upper incisors inclination is normalized,
Chúng ta đã tạo được cái độ trục của răng cửa
and
bình
this
thường.
is a
Ở
superposition.
đây là cái dòng hình của bệnh nhân.
A lot of intrusion in the lower,
Chúng ta tạo
right?
được rất là nhiều cái lỗ răng của hàm trên hàm dưới và lỗ răng cửa hàm trên hàm dưới.
And this is retention, very
Đây là
stable.
cái tình hình của bệnh nhân ở trong
And-
giai đoạn duy trì thì cái khớp cắn nó rất là ổn định ạ.
I'm sure many of you know that it's very difficult to retain a deep bite case, right? So what I do these days, I use Vao retainer because it covers the whole tooth surface, right? And it's really good for vertical control. So in deep bite cases, I really recommend use Vao. Or any type of ABP retainer, type of retainer, anterior bite plate. Another deep bite case,
Và một cái ca cắn sau khác
severe deep bite,
cũng là cắn sau rất là trầm
missing
trọng.
teeth,
Bệnh nhân còn mất răng,
crowding,
chen chúc răng,
transverse problem
bệnh nhân
here.
có vấn đề trên chiều ngang.
And you can see his incisors are very upright, and this is one of the reasons for the deep bite. And as we normalize the incisor inflammation, the deep bite will correct.
Thì nếu mà chúng
Right?
ta chỉnh sửa được cái trục răng cửa thì cái cắn sau của bệnh nhân cũng được cải thiện.
This is a clean
Ở
check.
đây là clean check của bệnh nhân.
I'm normalizing the incisor inclination
Và
and
chúng ta
at the
sẽ
same time
chỉnh
intruding
sửa lại cái trục răng cửa.
both upper and
Và
lower.
trong thời gian đó thì bệnh nhân lúng nó luôn. Các răng cửa hàm trên và dưới luôn.
Also, over-engineering, I try to make it almost an open bite patient.
Chúng ta sẽ tạo ra một cái clean check mà cắn hở luôn.
And this patient also
Và bệnh
is
nhân
class
này thì
2,
cũng
so
là
I'm
một cái
trying to
ca
correct
hạng
the
2.
molar key. I'm proclining the lower incisors
Và
and
thực hiện
intruding
với
at
cái
the
răng cửa
same
hàm dưới ra
time.
một chút xíu để chỉnh sửa cái toàn cũng như là
And
lực
I'm
cân
having
đối
the
được.
patient wear class 2
Và
elastics,
bệnh nhân này cũng được mang thung hạng 2,
aligning
sắp đều răng
and preparing space
và tạo
for
khoảng cho
implants.
việc đặt implant trong tương lai.
And another feature is the
Và một cái tính năng
bite
khác đó
ram.
là bite ram.
You can see here.
Vậy
These
thấy
bite
cái
rams.
bite ram không ạ? Bite ram
For
là
the
màu
bite correction.
xanh dương ở mặt trong của răng cửa.
So this is the start of treatment.
Thì đây là bạn trước điều trị và
I was trying to
tôi thì cố gắng để
align these molars because
sắp
I
đều
think
với
he
cái
had
răng
a
cuối này.
kind of a scissors bite.
bởi vì là bệnh nhân có cái tình trạng cắn chéo, cắn
And I'm
chéo
also trying to align the molars, the right molars, with
sắp đều
the
lên cái
NPA
răng cối
appliance,
hàm dưới.
mini tube appliance. And I take a lateral set, a progress lateral set, and I see that now His upper and lower incisors have normal
Và
inclination.
đây là cái phim lúc kết thúc điều
And
trị thì chúng ta đã tạo được
superposition
cái
of initial
trục của
and
ở trên và hàm
mid
dưới
treatment.
bình thường và trong hình.
So his incisors are normalized
Đây là cái
and
so sánh.
bite is corrected.
Chúng ta đã
And
đưa
this
cái
is
trục răng
another
của trên bình
additional
thường và chỉnh cái cắt sau cho bệnh nhân.
I want to intrude more.
Tôi muốn lúng thêm ở trên
Power ridges are placed.
và đặt thêm cái bow ridge.
And you can see I've over-engineered
Và tôi cũng chỉnh lố
to almost an open bite.
những cái răng, những cái đồ cắn phủ để thành cắn hở.
And you can also see here that the lower incisors
Mình nhìn thấy là
show blue colors here, right?
răng cửa hàm
And
dưới
this
nó cũng
means
có cái
that
màu
the
xanh xanh,
G8 protocol has
sọc
been
xanh.
applied.
Có nghĩa đó là cái gói G8 đang được áp dụng trên các răng này với G8 là kích hoạt KHAY đó, là hỗ
Okay,
trợ
the
lúc
lower
răng tốt
incisors
hơn.
first, and then canine, and then
Thì các
the
răng
molars
ở cửa nó sẽ
sequentially.
lúng trước và sau đó tuần tự tới răng nanh lúng
And
và
I
các răng
have
gối.
bigrams,
Và tôi có cái
the
bigram
palatal,
ở mặt ngoài, cái bow ridge ở mặt ngoài và bigram ở mặt trong của bệnh
and I
nhân.
also have aligner activation in the upper incisors.
Và hàm trên cũng có cái kích hoạt KHAY ở trên các răng cửa.
And his bite is getting shallow.
Thì chúng ta sẽ thấy là cái khớp cắn của bệnh nhân nó cũng được mở ra từ từ.
I'm trying to settle his bite.
Và sau đó thì tôi cố gắng để gài khớp cái phần răng
Fixed
gối.
retainer placed.
Và sau đó thì gắn
And
cái
I'm trying to settle
duy trì cố định răng lưỡi cho các răng cửa.
And this is the final result.
Và đây là cái kết quả cuối cùng của mình.
And because I want this to be very stable,
Tại vì là
I planned
tôi
for
muốn cho bệnh nhân
a
này
retainer,
có cái kết
removable
quả
retainer
rất
with
là
an
ổn định.
anterior biplate here so that
Rồi
it
đã
won't
làm
relapse.
cái thí cụ như là
So this is
như vậy.
2021, 2022,
Thì
but
đây là cái
nowadays I use Rivera
đây là cái
retainer.
ca mà tôi thực hiện xong vào năm 2022. Nếu mà bây giờ mà có ca tương tự thì tôi sẽ cho bệnh nhân mang Vivera để mà hoàn toàn
Very
che
stable
phủ cái
last year.
mặt nhai và cạnh cắn của các răng để
Then
đảm
we'll
bảo
set
là không
before
có
and
vết
treat
sau
after, before and
chụp
after.
cắn sau.
Superposition,
Và đây là cái
a
chồng
lot
hình
of
của bệnh nhân
intrusion,
trước và sau,
especially the lower
và tạo
incisors.
ra rất là nhiều cái lúng răng cả tuyệt đối lẫn tương đối và trải lại cái trục
And
răng.
this is after his implants and
Và sau khi mà
bridge
bệnh nhân
here.
làm lại cái implant và
Very
khung
stable.
hình khớp cắn rất là ổn định.
And lastly, I'm going to show
Và
you
cuối cùng
a
thì
case
tôi nói
that
về
I
cái
did, arch
bị
expansion
gân nông hàm
and mandibular advancement.
và cái kích thích phát triển hàm dưới ở trên bệnh nhân.
This is actually my friend's daughter.
Ở đây là con gái của
Class
bạn
2.
của bệnh nhân này ở cái tình
Short
trạng là
face.
khớp cắn hạng 2. Bệnh nhân này có cái
Class
gương mặt
2.
ngắn tầng mặt dưới thấp.
Severe crowding.
Bệnh nhân chen chúc rất là nhiều.
Actually, I told her that we might need extraction, but she really didn't want to extract. So I said, okay, I'll just do expansion and we'll see
Cho nên là
after.
thử xem thử là
And
bây
let's
giờ
see how it
tôi sẽ
goes.
thử nông hàm rồi xem thử như thế nào rồi tính tiếp.
Lateral ceph,
Đây
class
đây là cái phim
2,
sọ tiên của bệnh nhân hạng 2,
panoramic radiograph.
phim toàn cảnh.
This is after I delivered the
Rồi
attachment.
sau khi mà tôi gắn attachment của bệnh nhân, đây là cái clean check.
So I did a lot of arch expansion
Và tôi đã
because
nông hàm rất là nhiều.
there was severe crowding.
Tại vì là ca này nó chen chúc rất là trầm trọng.
And after I did expansion and
Sau khi
some
mà tôi
alignment, I planned for mandibular advancement
sắp kèo cho bệnh nhân
because
tạm
she
tạm
was a
thì tôi
growing child.
muốn làm cái máng có cái tính năng MA
And as I am aligning
dưới phát triển ra trước, nó sẽ có hai
I
cái cánh dài như
plan
vậy
for mandibular advancement.
để kích thích phát triển hàm dưới, đưa hàm dưới ra trước giống cái tuyến
So
block.
this is a lot of expansion
Thì mình thấy là nó nông rất là nhiều ha.
in the upper,
Ở hàm trên,
also in the lower arch as well.
hàm dưới cũng vậy luôn. Chúng ta vừa nông vừa đẩy hàm dưới ra trước.
So arch expansion
Thì chúng ta
It's
sẽ
very
nói về
easy
cái việc nông hàm thì nó rất là dễ.
for the teeth to tip buccally, right? When
nó rất là
we
dễ để
have
cho các răng
this
đi
expansion
ngoài.
forces. But
Khi
in
mà chúng ta
Invisalign, they apply
cái
a
từ mặt trong nó sẽ
optimized
đi ngoài các răng.
attachment here
Thì chúng ta sẽ có là cái gói G8
that
sẽ có cái
gives,
attachment
that
hỗ trợ.
creates that moment
Ở mặt ngoài như
for
vậy thì cái lực nó sẽ
minimizing
đi
the
vào
buccal
đó để
tipping.
nó giữ
So
cái trục của răng
this is
là nó
key,
giảm
I think, to
tối
this
thiểu cái việc đi
expansion
ngoài của
protocol.
các
This is also
thân răng
G8.
này và nó giữ cho thân răng bị nông.
So as we are expanding the teeth,
Thì khi mà chúng ta nông hàm
this optimized
thì
attachment
cái attachment tối ưu hóa
creates
nó sẽ
this
tạo ra
force
cái lực này
that leads to the buckle torque of these molars.
thì nó sẽ tạo ra cái tọt chân răng
So if you
về
just
phía
compare with the conventional expansion,
Cho
the
các răng
movable
này.
expansion,
thì khi mà chúng ta so
there will
sánh
be a lot of buckle tipping, right?
thì nó sẽ tạo ra rất là nhiều
But
cái sự
if
biến
we
phần
have
răng của mình.
this
Nhưng mà nếu mà
optimized
chúng ta có cái
attachment
răng mình
that
bên ngoài như vậy
creates a buckle with torque,
thì nó sẽ tạo
we
ra
can
cái
have
tọt
a
chân răng về
bodily
phía
expansion.
má cho bệnh nhân để trung hòa lại. Thì nó sẽ tạo ra cái
And
nông
this
hàm
is
tự
just
tiến
explaining
răng,
the
các
concept.
thân răng và chân răng luôn.
So optimized attachment is this one, and
Đây là cái
smart
attachment.
force. So they try to
Tối ưu hóa
expand
hỗ trợ.
one by one, to have a very efficient, effective expansion.
Và có thể là chúng
So
ta
if
sẽ
you look at
phân
the
đoạn
case,
ra nếu như cần di
we're
nông
expanding
hàm
and
thì sẽ
aligning
nông hàm
at
lực
the same
lượng
time.
các răng.
Also, we're doing MA, right?
Và trong một thời gian nông hàm thì tôi có thể làm luôn cái MA là cái
So
cánh dài
you can see her
để
mandibular
mà
growth,
kích thích phát triển hàm dưới cho bệnh nhân thì mình có thể sẽ nhìn cái sự tăng trưởng của bệnh nhân
and this
ở
is
hàm
the
dưới.
superposition. A
Đây
lot
là
of
cái
growth has happened,
trong
actually.
hình và nhìn thấy là
And I was
có
able
rất
to
là nhiều
treat
cái
her
tăng
with
trưởng của bệnh nhân đã
non-extraction.
xảy ra. Và đã
If you look at the
cái này là
numbers,
không cần cuối
the
cùng
A
thì
and
không
B
cần nhổ cái răng nào cả.
has been
Cái góc
changed
A
from
và B nó đã thay đổi từ
6.1 to
6.1
4.7.
về 4.7.
And the
Và
IMPA,
cái góc IMPA
yeah, one of the really good things about Invisalign is that the IMPA is preserved because
Cái góc
the
IMPA nó không có
aligner
tăng.
is covering the
Nó
whole
chỉ
tooth,
cực
and
kỳ
there are
là
also
giữ
four
nguyên
systems
97
to
đến 98
prevent
độ.
the lower inside
Nó
proclination.
không có làm cho cái răng cửa nó
So
bị nhẹ ra quá
IMPA was
nhiều trong
from
quá trình mà đẩy
97 to 98, only 1 degree.
tăng chỉ có một độ thôi.
And I'm finishing
Và khi mà tôi kết
with the
thúc thì
last
tôi
piece.
sẽ
So,
gắn thêm vết hình
right.
và mang thun như thế này để mà
So I was amazed how I could
tối ưu hóa
treat
cái
her
khớp cắn,
non-extraction.
ổn định cái khớp cắn.
I was kind of skeptical,
Mới
but
đầu tiên thì tôi khá
It
là
worked.
kiên dè ha, e ngại. Nhưng mà cuối cùng thì nó
and
rất là
these
hiệu quả luôn.
attachments are just to do some rotations of the canines. And I did some a
Tôi
little,
đặt
a
thêm
little
một
bit
vài
more
những
of
cái attachment để
expansion
mà
in the
chỉnh sửa lại cái
upper
trục của răng nanh,
as I was settling the posterior bite.
chỉnh sửa chi tiết một số cái vị trí của răng cho khớp cắn nó ổn hơn.
And this is right before
Đây là
debonding.
sau ngay trước
And this
khi
is
mà
the
tôi tháo
one
cái này. Và đây là kết thúc ạ.
Smells good.
Nhìn có thể tốt không ạ?
It's good. Compare
Nụ cười của bệnh
before
nhân
and
cải
after
thiện, góc mặt nhìn
image.
kia của bệnh nhân cải thiện và nụ cười cũng cải thiện,
Our facial profiles improved.
góc mặt nhìn kia cải thiện ạ.
So aligners is
Chúng
not
ta
the
không
shape
phải
of the tooth. So
đuôi nó
Invisalign
là thì
is
nó sẽ
a
không có phải là hình
force-based
dạng của
system.
răng.
It creates a
Nó
force
sẽ tạo
system
ra một
that
cái
is
khí cụ
designed
chính là những
to
cái hệ thống
achieve
lực
certain types of
để
tooth
mà tạo
movement.
ra cái di chuyển răng của chúng ta.
Take home messages.
Thì những
Invisalign
cái,
innovations are
thông điệp
based
mà tôi
on
muốn,
biomechanical
mọi người nhớ sau
principles.
cái bài này đó là cái những cái
And the
phương pháp
Invisalign
của
system is
Invisalign
a
là dựa vào
force-based
những
system.
nguyên tắc của sinh cơ học.
And the
Và
three
hệ
keys
thống
to the
Invisalign, hệ
Invisalign
thống
innovations
tạo ra lực
is
do
smart
lực
material,
và
smart force
những cái
features,
yếu tố
and
rất
smart
là quan
staging
trọng về
technology.
vật
They
liệu
all work
như
together
góc nếp,
to
thông minh
provide
và góc địa
excellent
lực,
tooth.
phân đoạn thông minh
And smart
làm
force
gì mà hỗ trợ
aligner
để tạo ra
activation.
cái kết quả kiểm soát răng rất là tốt.
I mentioned that aligner activation is changing the shape of
Đó
the
là
aligner,
chúng ta đang thay đổi
not the
cái
tooth,
hình dạng của
by
cái
adding
má
attachments.
mà không phải là
Um,
thay đổi
Align
hình dạng của
is
răng và cái attachment mà
doing
thay
a
đổi
lot of
hình dạng của
research
má.
on aligner activation,
Và chúng
so
tôi
that
đã
this will minimize the
chúng ta
use
đã
of
có rất là nhiều cái
attachments.
nghiên cứu
So
để
they're
mà
trying to change
nghiên
the
cứu
shape
ở
of the
trên
aligner
cái việc là
to
cái
apply
mặt
forces
cái máng như thế này
to
thì chúng
keep
ta sẽ
where they
cố
need.
gắng giảm thiểu cái việc gắn attachment và
And
vẫn
they're
đạt được
continuously
hiệu quả
researching
di
on
chuyển
this
răng.
and has tremendous potential.
Và sẽ có
And lastly, I really
chúng ta
want
sẽ
to
tiếp tục nghiên
stress
cứu và thấy rằng
diagnosis
nhiều cái
and
tiềm
treatment
năng để
plan
phát triển ở
is
trong cái mảng này.
fundamentally
Và cuối cùng
important.
thì tôi muốn nhấn mạnh lại
Clinical
là
design
cái chìa khóa để
is
thành công
important, of
trong
course,
một cái điều trị
and we
Invisalign
need to understand the
đó
biomechanics.
là
And
quan trọng
lastly,
nhất là bệnh
patient
nhân
compliance.
phải
If
rất
the
là hợp
patients
tác
don't comply,
và thiết kế
this
clean check
whole
và
thing
dựa
will
theo
not work.
những cái nguyên tắc
So
sinh
you
cơ
should
học
make
chẩn
sure
đoán và
that
lập kế hoạch điều
patient
trị
compliance
phù hợp cho
is
bệnh nhân.
important and educate
Thì
the
cái quan
patient
trọng nhất
to
đó là
wear
bệnh nhân phải được giáo
full
dục
time, at
để
least
mang
21
máng
hours
ít
out of
nhất là
24 hours.
22 giờ một ngày.
And Vivera, I
Và
started
đây là
using
cái
them.
Vivera.
At first, I was skeptical, actually,
Thực ra thì ban
but
đầu tiên
nowadays
thì tôi
I'm trying to use
khá
more
là
and
do
more,
dự
and
ngại
I'm
ngần.
seeing
Nhưng mà bây giờ
really
thì
good
tôi đã
results.
sử dụng nó rất là
Because
nhiều.
with
Cái
fixed
máng
retainers,
Vivera này
they have many
nó rất
problems.
là hiệu quả.
And
Những cái
I'm really enjoying using mirror and trainer as
có
well,
rất nhiều vấn đề.
especially for
Hiện tại thì tôi
the
đang
cases that
cái,
require vertical
sử dụng Vivera rất là tốt
stability,
và
such
tôi
as open bite
đang
and
sử
deep
dụng
bite.
cách rất
Thank
là
you.
thoải mái. Đó là cái bài
Thank you very much, Dr. Yoon-Ji and Kim, for a beautiful presentation and a study for the biomechanics for clear aligners. So we're going to have